So we can start today's session, and today we will start with injuries of the lower limb, and starting with the very important entity from which we have a question almost in every session, whether it is FMG, NEET, PG, or even INICAT. So that is posterior hip dislocation. Now, out of all the types of dislocations, of course, the posterior hip dislocation is the commonest, and I think most of you must be knowing what is that characteristic deformity of the lower limb in posterior hip dislocation. So that is fadir. Clear? So that is the characteristic fadir deformity. Now F is for flexion, A is for adduction, and IR is for internal rotation. Clear? So this is the characteristic fadir deformity. Now the usual mechanism is like if somebody is sitting in the front seat of the car, and if there is any accident, the knee strikes the dashboard, and then the force is transmitted along the long axis of femur, and that dislodges the head of the femur out of the acetabulum. So sometimes you also call it a dashboard injury. So the another term for this is dashboard injury, right? Now on X-ray you will see certain important features. Yes, Shanawaz bhai, this is dashboard injury. One is a broken Shenton's line. Now whenever we order for X-ray, especially in case of hip joint, we always include the uninjured or the normal hip joint in the X-ray for comparison, right? So what we say, X-ray pelvis with both hips, right? Of course this one is AP view. So we are including the normal side as well, and that helps us in actually comparison, right? So if you see, this side is normal and this side is the injured side. Now we were discussing about the Shenton's line, and let us see what actually the Shenton's line is. So what we need to do, we have to draw a line along the medial border or the medial part of the neck of femur, and if we extend it furthermore, this is the inferior pubic rami, right? So this is a smooth curved line, something like this. So medial part of the neck of femur and the inferior border of the superior pubic rami. So you can draw a smooth curved line. But if you see on the affected side, this is the medial part of the neck of femur, and this is the inferior border of the superior pubic rami. So obviously you can see that there is a break in Shenton line. So one thing is broken Shenton line. Now this finding is not specific to hip dislocation, because it can be seen in any entity, in any injury where there is disruption of the normal anatomy of the hip joint, right? So it can be neck of femur as well. So it is not specific for posterior hip dislocation, that you should know. It is just that it is one finding here, right? So one thing which you will write here is broken Shenton line, right? This is one finding, and this is again a continuous curved line, okay? And this is formed by the medial part of neck of femur and inferior border of superior pubic rami, right? So this word is very important here, superior pubic rami, inferior border. So don't take it for superior border of inferior pubic rami or inferior border of inferior pubic rami. So just make sure that these words are quite clear to you, right? So this is broken Shenton's line. Now, one more thing which we can see here, since there is internal rotation deformity, so what happens? The lower limb rotates something like this, and as a result, this prominence of lesser trochanter, right? So this is the lesser trochanter, and this is not perceived here, right? So if you draw like this, you will not find the prominence of lesser trochanter, because by the internal rotation it has gone somewhere behind the shaft of femur, right? So it is not visualized. So that is one very important feature. Lesser trochanter is not visible. Clear? And it doesn't mean that it disappeared. It simply just because there is internal rotation deformity, and therefore it moves behind the on the posterior aspect of the shaft of femur. So internal rotation. So this is an indicator of internal rotation. Now you can also see some adduction here, right? So adduction is clearly can be observed here, and this is the acetabulum here, right? So this is the acetabulum, and one can easily see the head of femur which has gone outside. So it is clearly a dislocation, right? So obviously this is dislocation, and since lesser trochanter is not clearly seen on the X-ray, it is more indicative of posterior hip dislocation, right? So this one is quite indicative of posterior hip dislocation. Okay, now all dislocations, they are emergency, and all such joints have to be reduced on an emergency basis. So the management is emergency reduction. Now reduction means the head of the femur, it has to be pushed back into the acetabular cavity. So that is reduction. So here we have Stimson's gravity method, or we can use Ellie's maneuver. So, and yes, at times we need to reduce the joint under general anesthesia, because there is so much of muscle pull, and it makes the reduction very difficult if you don't give muscle relaxant. So we have to give a short GA so that the muscle pull is, it becomes little weak, and that help us in reducing the joint. So general anesthesia is needed here, and the complication is that a nerve which is passing behind can get injured. So there can be injury to sciatic nerve, right? So this is the important points which you should know for posterior hip dislocation. The another important injury in relation to the proximal femur, you can say, is the fracture of neck of femur. And if you see here, I have specifically written a word. This is intracapsular, right? So fracture neck of femur, intracapsular. Now why I'm just stressing on this word here, it means the fracture line is inside the capsule of the hip joint. So suppose if this is the acetabulum and this is the head of femur. So this is the territory of the capsule of the hip joint like this. Okay, so this is all the hip, the capsule of the hip joint. Clear? So intracapsular means the fracture is somewhere here like this, right? So it can be anywhere within the territory of the capsule, then it is known as intracapsular. Because there is one more variant where the fracture line is outside the territory of the capsule, and this is the extracapsular variety. So this is the extracapsular, means outside the territory of the capsule, and this one is intracapsular means within the capsule of hip joint, right? So I'm specifically discussing the intracapsular variety here. Now there are different classifications. One is anatomical, Powell's or Gardens, and this kind of injury is especially seen in elderly people. So it occurs in elderly, right? And this can occur even after a minor injury, right? So this is very important here. This can occur even after a minor injury. It can be a simple twisting of leg. So even a minor injury is sufficient enough to break the neck of femur. And why it happens so? Because the bone has been weakened by the process of osteoporosis, right? So in majority of the cases, the patients are elderly, especially if ladies, postmenopausal lady, and there is a history of minor injury, and that may be a fall in bathroom also. So all these they are sufficient enough to break the neck of femur. Now here, the classical deformity is external rotation of leg, right? Now this external rotation of leg will be seen in both intracapsular as well as extracapsular. Since the fracture line is outside the territory of the capsule of the hip joint, so the amount of external rotation is too much. So it is more than 45 degree. But since the fracture line is within the capsule of the hip joint, so it doesn't allow much of external rotation. So here the external rotation is less than 45 degree. So this is one important clinical difference between the two varieties, the intracapsular and the extracapsular, right? So in intracapsular, there is external rotation deformity of the lower limb, but the magnitude is less than 45 degree because the capsule, it prevents free external rotation of the lower limb. Then there might be shortening, and of course the movements will be extremely painful. One should not try doing all this, and there is no active straight leg raising, which is known as SLR. So straight leg raising. Now these are all theoretical terms. We should not do all these things clinically because it is extremely painful for the patient. So this is just for theoretical concept, right? So this is the clinical presentation. Now again, when we see that the X-ray, we will easily see the fracture which is extending across the neck of the femur. So there is a break in the cortex of the neck, and more evident is the external rotation deformity of the femur, right? And sometimes there is overriding of greater trochanter so that it can be seen reaching up to the level of, now this is the greater trochanter, right? And this is the outline of the head of femur. So you can see it can come somewhat at the same level. So there might be because of the proximal migration, and that what actually leads to the shortening of the lower limb. So there can be overriding, and of course we have already discussed about the Shenton's line. So there will be a break in Shenton line if you try to draw it. Now this is the inferior border of superior pubic rami, right? So this is inferior border, superior pubic rami, and this is the medial border of the neck of femur. So you can see there is a break in the Shenton's line, of course, right? And we can also see break in the tubercular stream. signifying a fracture. Now treatment is always operative. In children's we can use some Moore spin, right? So this is again Orif or Nowley spin. So this is again open reduction, internal fixation. In adults we have to do Orif, and here we can use multiple cannulated screws, right? Cortical cannulated screws. So this is in children and in adults. Now especially in elderly people who are above the age of 60 years, this will not work properly because of, yes, Shanawaz bhai, or if we need to do Orif. Now this multiple cannulated cancellous screws won't work here because the bone is osteoporotic. So what we will do? We will do hemi replacement arthroplasty, right? So we will do hemi replacement arthroplasty, and when I say hemi means half. So what we will do here, we will remove this much area. Okay. So we will remove the fracture head and neck, and also this much area, this much, all area will be removed, and it will be replaced by a prosthesis. It can be Austin Moore, or we can use a Thompson's prosthesis. And sometimes we also prefer doing a bipolar replacement surgery, right? So these are all surgical, options available with us. Then for vascularity, we can try a Mears procedure. If it is going into, if you feel that it is taking a lot time for union, or it is going towards non-union, we can try a vascularized graft, and that is Mears procedure. And we can do a McMurray's osteotomy for mechanical axis realignment in cases of non-union of neck of femur, a fracture neck of femur. Right now, why this fracture is so problematic? Because there is high chances of going this into non-union, right? So high chances of going into non-union. And another is avascular necrosis. And sometimes there are cases which have been managed operatively. We have done Orif, the fracture has united, but still the head of femur has gone into AVN. So this is a problematic complication with this injury. And to understand the concept of this AVN, again you have to understand the blood supply of the head of femur, which goes in this manner. Okay, so the blood supplies goes in this manner, and therefore if fracture is somewhere here, it can break these, it can rupture these blood vessels, and this all part can go into AVN, right? So this is the reason for AVN, because of this peculiar arrangement of blood supply for the head of femur, right? So in cases of fracture neck of femur, especially intracapsular variety, if there is AVN, that will involve the head of femur. So as a student, from exam point of view, you should remember two things: which fractures can get AVN as a complication, and if complication is developing, which part of the bone it will be seen. It will be seen in, right? So here AVN will be seen in head of femur. In previous session, we discussed about AVN of scaphoid fracture, where we discussed that the proximal part of the scaphoid will undergo AVN. Here you need to remember that it is the head of femur which will undergo AVN. right? So this is very important here. And when there is AVN, obviously there will be, loss of the rounded contour of the head of femur, and later on there is possibility of development of osteoarthritis. So just remember these three complications. Obviously non-union and avian is a very problematic complications coming out of this injury. So in children's, or if with Moore's or Knowles pain. In adults, multiple cannulated cancellous screws, sometimes we write it as CCS. In elderly, now this is asked many number of times, so that is hemi replacement arthroplasty with Austin Moore or Thompson's prosthesis. We also do bipolar surgeries, and then Mears for vascularity, right, and McMurray's for mechanical alignment. So just remember this much for intracapsular neck of femur. Now here I have kept specifically this extracapsular entity, because I just want to mention 2-3 contrasting differences of extracapsular variety, which is also known as intertrochanteric fracture, right? So the another term for this entity is intertrochanteric fracture. Now I think all of you must be knowing what is inter. Inter means between. So the fracture line is running from the greater trochanter, and this is the lesser trochanter. So the fracture line is running across a line which is connecting the greater trochanter with the lesser trochanter. So this is intertrochanteric fracture. Obviously there is no restriction of the capsule, so the lower limb can rotate freely, and sometimes we can see even up to 90 degree of external rotation deformity. Now what is one more important point which you need to remember here is that the treatment is by, again, Orif with dynamic hip screw, right? So this is dynamic hip screw, right? So this is dynamic hip screw, or we can also do a PFN, right? So proximal femoral nailing. So proximal femoral nailing. So just remember the names, right? So these are the treatment options. And one of the good thing with this extracapsular fracture or the intertrochanteric fracture is that it unites very well as compared to intracapsular fracture, which can go into non-union. So here union is quite good. Union is good, but the only problem is that it can unite in some wrong position, and that is known as malunion. Clear? So this is malunion here. Union is good, but sometimes it can unite in little wrong position, so that is malunion as compared to non-union, which we see in intracapsular variety. So these are the 3 important differences which you should know. One is in terms of the external rotation deformity, second is in terms of the management, and third in terms of the outcome. Extracapsular will unite, but will unite in a slightly wrong position, that is malunion, but intracapsular variety can go into non-union and avian, of course. So this is a very important segment from where question is usually framed. Then coming to fracture of patella, and there are 2 mechanisms in which the fracture can occur. Sometimes there is a direct force, right? So there is a direct hit over the patella, which can be seen in road traffic accidents, and there is either stellate, that is star shaped fracture, or there can be comminuted fracture. Now comminuted means more than 2 fracture fragments, right? So usually we see there is a single fracture line and there are 2 bony parts, but here there are more than 2 bony fragments, and therefore we will call it a comminuted fracture. So this is the definition of comminuted fracture. Sometimes there can be a indirect fracture when there is a strong muscle pull by the quadriceps femoris muscle, and that will create a two-part fracture, right? So two-part fracture is somewhat like this, right? So this is a two-part fracture. Anyway, the patient will have pain and swelling over the knee joint, and there is extensor lag, because we know that the quadriceps muscle, quadriceps femoris, right? So there are four component under this. Then there is patella, and below this there is the ligamentum patelli. So this is the ligamentum patelli, which inserts onto the tibial tuberosity. So here is tibial tuberosity. Right? So this quadriceps femoris is the extensor of knee joint. Clear? So if there is any fracture somewhere here, obviously the pull will not be transmitted properly, and there will be a extensor lag. So patient is not able to lift the lower limb with knee in full extension, right? So this is just because of fractures of patella. Now, the conventional X-ray views are AP and lateral, but in case of patellar fracture, we can go for an additional view, and this is the skyline view, right? So we can go for an additional view, that is skyline view, right? So treatment wise, we have to look at the fracture line here. Now if you see here, this is the fracture line, okay? So if it is an undisplaced fracture, we can go for a cylindrical cast, right? So we can go for a cylindrical cast, right? And the cylindrical cast, it extends from the groin till the ankle joint. It does not immobilize the ankle joint. So that is an important feature here. So groin till ankle. Just remember this. This is the extent, right? So sometimes also known as tube cast. Then if the fracture is displaced, it means if the bony fragments are something like this at a distance. Now here we need to do a tension band wiring. So this is a tension band wiring. Clear? So undisplaced means the fracture is something like this. The fragments are very close enough and they can be simply managed in a cast. But displaced, it means they have moved apart. So we need to do a surgery, and that is tension band wiring. So we will pass two K wires like this, and then we will use a stainless steel wire to make a figure of 8 kind of loop, right? So this is tension band wiring. And for comminuted fractures means too many fracture fragments, we need to remove some part of the patella, and that surgery is of course known as patelectomy, right? So this is patelectomy. I think all of you must be knowing what is ectomy. Ectomy means surgical removal, okay? So this is surgical removal, right? So depending on the type of fracture, you will decide the line of treatment. And here for tension band wiring, I think we can just take couple of words more. It is, the principle is distractive forces are converted into compressive forces, right? Converted into compressive forces. So it means when the patient try to flex the knee, it will rather bring the fragments closure, right? So distractive forces are converted into compressive forces, and this is also done for fractures of olecranon process of ulna. Clear? We can also do it for fracture medial malleolus, but from exam point of view, just remember olecranon process as well. So this is in short about fracture of patella. Then coming to ACL tear. I think most of you must have heard of Rishabh Pant having this ACL tear, and such beautiful is the result of reconstruction followed by, of course, rehabilitation, that he is playing the game again. So this is the most commonly, right? So it is the most commonly injured ligament of the knee joint as compared to posterior cruciate ligament or the collateral ligaments. And the function of the anterior cruciate ligament is to prevent anterior movement or anterior translation of tibia over femur, right? So suppose if this is the lower end of femur and this is, say, tibia, so if this is the ACL, it makes sure that there is no forward movement of the tibia over femur. So this is tibia and this is femur and this is of course ACL, right? So it makes sure that there is no forward translation or forward movement of tibia along the long axis of femur, right? So this prevents this anterior translation, and therefore if there is any break here, if we try to pull the tibia forward, it will easily move anteriorly. So this is the basis of this anterior drawer test. We try to pull the tibia anteriorly, and if there is no restriction by the ACL, we can easily pull the tibia anteriorly. So this is anterior drawer test, but for this we need to bend the knee to 90 degree, right? So this is the requirement to perform this test. Now what happens when there is ACL tear? There is already so much of pain, patient does not allow to bend this much. So we can do another test where we need to bend the knee joint to only around, say, 15 degree. So bend the knee around 15 degree, and the principle is same. We are checking the anterior translatory movement of the tibia over femur, right? So the procedure is same. Only the position of the knee, the amount of flexion over the knee differs. In anterior draw, it was 90 degrees, so it was extremely painful for the patient. So we developed another test in which the knee needs to be bent only 15 degree, and we can simply look for the anterior translatory movement. So that is the two clinical tests for ACL tear. And in terms of history, patient will hear a popping sound and he will feel as if my knee is becoming unstable or it is giving away under pressure, right, as compared to the other uninjured side. So this is the presentation by the patient. Now since it is a soft tissue injury, so we have to always go for MRI, right? So in the MRI we can see, classically we can see a tear in the ACL, right? So this is the attachment of ACL over the tibia, and then this is over the femur. So we can see a tear, and again treatment wise we need to do ACL reconstruction, right? And we can take a slip of ligamentum patelli, right? So just remember this much for ACL tear, which is one of the commonest injury, especially seen in sports. So sports injury, right? can be football or skiing. Clear? So this is ACL tear. Then another important fracture in lower limb is fracture neck of talus, which is also known as aviator's fracture, and it is especially seen in pilots who jump off from the planes in case of crash or some other engine failure. So when they develop this neck of femur fracture, neck of talus fracture, extremely sorry. So therefore it is known as aviator's fracture. So it is especially seen in pilots who jump from the plane. And again, this is one very important injury which students must know, because one of the complication is avascular necrosis, right? So it can develop avascular necrosis, and here if you look in the X-ray, you can clearly see a black line. This is the fracture actually, right? And the avian, because the blood supply is coming something like this, distal to proximal. So what happens if there is a fracture somewhere here? Again, it is going to disrupt the blood supply to the body of the talus, right? So this is the body of the talus, and therefore the body of talus can go into AVN. So AVN of which area? Body of talus, right? And this is because of the peculiar arrangement of the blood supply, which flows from distal to proximal, and it passes through the neck of talus. So whenever there is fracture, there is all possibility of the tearing of those arteries which are going to supply the body of talus. So there is possibility that if these arteries are torn, then the body of the talus might become avascular, and then it can go AVN. Now, in a given case of fracture neck of talus, how we can say whether it has gone into a state of AVN or not? So for that, we have a very beautiful Hawkins sign, which actually tells us whether a fracture has gone into AVN or not. So if this sign is positive, it indicates a good prognosis, right? So if Hawkins sign is positive, it indicates a good prognosis. And when we say good prognosis, means that the blood supply to the body of talus is maintained. So maintained or retained vascularity of the body of talus. So this is a Hawkins sign. If positive, it is very valuable, and it indicates vascularity, right? So it shows that there is no AVN in the body of talus, and this is noticed around 2 months after fracture. Now, how we see it on X-ray? It is actually an area of subchondral radiolucency. Now, when I use the word lucency, it means black impression, right? Because white impression on X-ray is radio opacity, and radiolucency is black impression. Now I am using these layman kind of words, please pardon me, but it will just to make sure that you understand the word easily. Now sub means below, right? And chondral means cartilage. Clear? So what actually we see in the, if suppose this is the talar dome, we are interested in looking for a black line, something like this. So this is subchondral radiolucency, right? So this is radiolucency. If you can see this is of course talar dome. So if you can see a black line after 2 months of fracture of neck of talus, you can be very happy that the body of talus has not gone into AVN. So this is actually a radiological indicator or radiological predictor whether the fracture neck of talus has resulted in avian of body of talus or not. So if it is positive, it's a good sign. And how we say it is positive? We can say that there is radiolucency. So this test is, so Hawkins sign is positive. Clear? And positive, it's good prognosis. Fine. So just remember these three things: radiolucency, positive test, good prognosis. So this much is enough for this session. I'll get back to you with some more topics in next session. Till then, thank you. Goodbye. God bless.